Top Med Talk.
Hello, I'm Desiree Chappell, and this is Top Med Talk. We're coming to you with the coverage of the COVID crisis from the front lines. We've had conversations with all types of care providers all over the world who are battling this virus, and we're going to continue to share those stories and those also who are supporting frontline workers and hope to continue to provide education and support for those of you who are taking care of COVID patients. Now, today I'm joined by not our usual co-host, Monty, but I have another one of our partners in Top Med Talk, a newly designated Dr. Henry Howe. How are you, Henry?
Hi, Desiree. That sounds quite nice.
I bet it does. We did a huge shout out to you, man. So if you're a Top Med Talk listener, you've heard that Henry Howe is now a doctor. So congrats to you. We're very proud of you, Henry.
Thank you very much, Desiree. Thank you. It's great to be on here.
Yeah. For those who did not listen to the earlier podcast, so can you walk people through a little bit what's happened in the last couple months?
So I'm at Bristol University, or was at Bristol University. About 2 weeks ago now, we were graduated early. We were supposed to graduate in July, but they brought everything forward so that we can then join the front line and join as doctors and help with prescribing and doing ward rounds. Originally, they talked about us doing more of the ward-based cover stuff, so not necessarily treating COVID patients, but I think that might even be changed.
So you've been through this accelerated type, time frame, and there in the NHS, they've decided to put you guys, instead of waiting all the way until August, to go ahead and put you on the front lines. Talk to me from the perspective of a new doctor who probably already has some anxiety about going into the field. Tell me how, this COVID crisis has maybe changed that a little bit, or if you're feeling, maybe more anxious or...
Starting work in any sort of shape and form is always scary. So August was always going to be a scary thing anyway. And now starting potentially next week, so it does pull on the nerves, and I am a bit worried. But at the same time, I do feel as if I will be well supported. I do feel as if the staff are there and people have already reached out to say, if you need help, come to us. So hopefully it will be smooth and we'll feel well supported in the environment.
Yeah, that's absolutely fantastic. Well, let's introduce our guest. Henry, can you introduce your colleagues here?
So we've got 4 doctors who are at Southmead, F1 doctors. So in the UK, F1s are the foundation year 1 doctors, so junior doctors. So first of all, we have Dr. Dolcie Paxton. Do you want to say hi there, Dolcie?
Hello, everyone. I'm Dolcie. I'm one of the doctors based in Bristol.
Brilliant. And then we've got Dr. Beth Robinson.
Hi, everyone. I'm Beth. I'm from North Yorkshire. And I'm also working in Southmead Hospital as a FY1.
Then we have Dr. Jessica Hatrick.
Hello. I'm working with these two also in Bristol. I'm from the kind of south of England and trained in London.
And then Dr. Chloe Hall.
Hello, my name is Chloe and I trained at UCL and have moved to Bristol to start work this year.
And the 4 of you all live together in Bristol and are all working at Southmead. Yep. You've now been doing the job for 8 months, 9 months now. And then COVID's come along and hopefully you're feeling prepared. But I assume that there is a bit of anxiety amongst yourself as well. Chloe, do you want to talk a bit about that?
So, it's scary enough starting a new job when you kind of at least know what might be happening and you have your 3 different rotations outlined for you and you have an idea of what's going to happen. And then suddenly halfway through the pandemic hits and everything's thrown up in the air. We didn't know where we were going to be working, what the structure of the hospital was going to be like, whether we were going to be completely change shift patterns and things like that, and it's all been sort of going along as we go really over the last few weeks, which has been quite scary. Yeah.
Chloe, let me ask you a question. You said that things have been thrown up in the air, and you normally at this time in your all's foundation year program or foundation years program, you would be rotating through different types of hospital settings and care settings. So was everything just absolutely frozen and you kind of just are stuck where you are, or was there any kind of planning for that? Or
yes, in the UK, for the first 2 years of your training after you graduate, you change rotations every 4 months. So you're meant to do a total of 6 rotations throughout those 2 years. And we've just completed 2 rotations and we were due to switch last week. But because the whole hospital has been restructured, structured, there now aren't rotations as such, and so it's now more sort of COVID versus non-COVID, as opposed to all the different specialties, respiratory, gastro, cardio, things like that. So it's sort of totally changed.
Gotcha. So, Jessica, if you can tell me, it sounds like you all were then frozen there and headed in Southmead. Can you tell us what rotation were you in at the time?
I was on the respiratory ward, which kind of my 4-month block, and I was due to be moving on to the acute medical unit. My only other job I've done was psychiatry, so I was looking forward to kind of getting a change, but now this COVID crisis has hit, and it seems like, all our patients have respiratory problems now. So I do feel actually quite a bit more comfortable with the kind of patients that we're seeing, but I didn't move on to the acute medical unit. And as Chloe was saying, we've all now got onto this kind of new, just COVID or non-COVID based rota. And we've received a new rota that starts next week. And it'll be interesting to see, you'll be in a new team. We're kind of thrown in the deep end a bit, moving around different wards. So it'll be interesting to see how that changes the job a bit for us. And it's all going to be very new and different, but hopefully we'll see that things are a bit more streamlined and we're able to tackle this kind of ahead of time before we get overwhelmed by patients like we've been seeing in other countries. So that's, I think, the plan, really.
Yeah. And for our listeners, Beth, can you give us a little bit of an idea of what the hospital system or I guess the actual hospital there in Southmead looks like? Number of beds, number of critical care beds. Do you know those stats?
Yeah, so Southmead Hospital, where we all work, is one of 2 major hospitals in Bristol. So there's the Bristol Royal Infirmary and Southmead Hospital. So we're all in Southmead. It's quite a relatively big hospital, also a very new build. It was built in 2014, so it's all still nice and shiny. We have a very big intensive care unit. So there's 4 different pods in that unit. I'm not certain of how many beds are in each pod, but I believe it's somewhere in the region of 60 to 70 beds in total, which is quite a big ICU compared to the rest of the country. And the hospital in general, gosh, I'm not sure how many beds. I think it must be in the region of 1,000 to 2,000. And the hospital's split into 3 blocks, really, it's quite clever. It's a bit of an interesting build. So there's different zones, and all of the wards are incorporated in those different zones. So the acute block is all in one. So it includes A&E, acute medical unit, the acute surgical unit, and then all the other blocks sort of house the general respiratory, cardiology, gastroenterology wards, etc.
Gotcha.
So I was thrown into geriatrics, which I suppose is quite relevant currently. I was on respiratory first, so I've also got a little bit of a background that I'm pleased to have at this time. I was about to go into surgery, though, which is quite disappointing because I won't have another surgical placement. So I'm not sure how that's going to work in the future if I did want to go down a surgical route. So I've been frozen in geriatrics currently. And I am staying on what we call one of the geriatrics ward. So it will be a COVID positive ward, but it will be specifically for the geriatric patients. So it'll be quite useful to have the skills that I've gained over the past 4 months.
Sure, yeah.
So Beth, the geriatrics ward that you've been working on with Dolcie, it's been turned into the COVID positive ward, and it turned into the palliative COVID ward.
Yeah, I mean, the hospital is changing so quickly. Every hour something new comes out, and all the wards are being rejigged into different sort of areas. So it was previously the COVID frail ward. So it was unfortunately where a lot of patients would pass away who were COVID positive, but it's been changed again now. And I believe it's sort of anyone who's COVID positive. So we have got a few younger patients as well, but generally, obviously the general age of patients who have got COVID are the elderly. So we do have mostly elderly patients still in our ward and everywhere in the hospital.
And Dolcie, how would you say COVID impacted how you deliver your care as a junior doctor?
When I first started, I did a 4-month block in psychiatry and then went straight to a care of the elderly ward. So they were both quite unique experiences. But throughout both of them, I got to spend quite a lot of time with patients and get quite involved with their care. But that's completely changed, really, in terms of how we're managing patients at the moment. So obviously, we're not allowed to spend as much time as possible with patients now if they're positive because of the risk of exposing us to the virus.
Yeah.
And then also the fact that we can't meet up with families as much as often. So I think it's just changed how we're communicating and how we're practicing, really.
In the UK, the death numbers are going up, unfortunately. But along with that, we've heard 19 NHS staff have also, unfortunately, lost their lives to COVID. Are you worried about this as frontline workers? Is it something that concerns you?
It is concerning because PPE guidelines have been changing so quickly and so frequently that I don't think any of us are quite sure. We do have clear guidelines now, but they've only come out recently. It is scary. Us as a house ourselves, we've already self-isolated. Me and Beth have both had symptoms of COVID and we're both quite unwell. And our 2 housemates had to stay off work for 14 days. So we feel that we've already caught it, but it's difficult to know because we aren't tested.
What was the reasoning behind the not testing?
Well, this was a few weeks ago now, so it was probably more of a government-based decision. There just wasn't enough capacity to be testing staff or people that weren't critically unwell in hospitals. But obviously that's changed now in different areas. I know Southmead Hospital are starting to test staff in self-isolation.
On the PPE front, so the protective equipment, there's a lot of news, a lot going around about the shortage or the distribution of PPE not being sufficient. Jessica, have you noticed any of this?
When this all started, we weren't really sure of the scale of, how much PPE we needed and what specifically was needed. So I think there were some issues, but I've found I'm working on the respiratory ward where there's quite high dependency patients who are using what we call aerosol generating procedures, which need kind of highest levels of PPE with the visor and special gowns. And I felt pretty safe on the ward. I felt like there's been enough equipment and I've been able to kind of care for the patients as I've needed and not felt the risk of exposure. But I know this can be different in other trusts. But I think, our hospital's done a good job of making sure that we feel that at least if there's not any there and then, we don't feel under any pressure to put ourselves at risk. And everyone's been really supportive about making sure that you're not putting yourself at risk for your patients, because that's not something that anyone wants to see. As you mentioned, staff have been very sadly affected by this, and we just want to make sure that we're as safe as we can be.
So Jessica, you told me that you did a psychiatry round before your current round in respiratory. When we deal with end of life, and as a critical care nurse myself for years in working in anesthesia, end of life it's a difficult subject anyway, and it's very difficult to deal with as a provider because, there's many different issues and different personalities and all those different things. But you usually can do that together and collaboratively, and it doesn't seem like that is what's happening now. Is that what you're finding?
It's all very unknown, and I think these patients are becoming quite unwell quite quickly. And so I think we're realizing the importance of having a very clear approach to end of life and making sure that we get it right, because it's obviously a really important time for both families and patients, and making sure that where families can't come and visit their loved ones, we're giving them regular updates. We make sure that everyone knows what's going on, and also we make sure we support staff, because as you mentioned, it's a really difficult time when I think so many more patients are unfortunately passing away with this virus, as I said, in quite a quick way. We need to make sure that everyone feels supported and you're able to talk about things, and the doctors, more senior doctors, especially for us juniors who haven't necessarily seen so much people so unwell, kind of all at the same time, are there for us. And I think that's been done really well at our hospital. I don't know if you guys would agree. We've got lots of well-being support out there, especially for junior doctors. There's lots of sessions they're putting on and a kind of central hub that we can go and kind of relax in and take some time out if we're feeling really overwhelmed. And lots of people have got different experiences of moments that they've just found it all a bit much already. And so, yeah, I think we do feel well supported. And I think as things are going to get more difficult, I think that's really important.
Yeah. Chloe, do you kind of feel the same way? Has that been your experience as well?
I don't know how much you guys have talked about it before, but one thing I think that is really good that's coming in is that whenever any patient comes into hospital, we're getting much better at asking them questions about sort of what might happen to them in the future, what might happen to them if they become unwell, and what might happen to them if they get to a point where their heart might stop beating, they might die, and whether we would resuscitate them or not. And I think that previously these have been quite taboo things to talk about, and it's been quite difficult, and it's often been left to a very senior person to have that conversation. And I think we as junior doctors have had chances to become better and easier to have these conversations with patients, especially as they're coming through the front door. And I think it's a really important conversation to have. Yeah,
that's true. That's very insightful. We have all different ways to intake patients and do those initial patient questions. And, do you have advanced directives, what we call them in the US? So do you have any, do not resuscitate orders or anything like that? And it's usually something that we gloss over quite quickly. Is that something that you are actually having that conversation with? And when you do, is it something that still is kind of like yes or no kind of thing, or are you able to have some more robust discussion with the patient?
Now, whenever, each patient comes into hospital, they're having these discussions at the front door. So in our admissions unit, the acute medical unit, or in the emergency department, every patient who comes through there has what's called a treatment escalation plan in place. And this is, it's literally a tick box as to whether they are for a ward-based care, which is things like oxygen and antibiotics, whether they would have something a bit more invasive, like non-invasive ventilation or CPAP, or whether they would be for intubation and ITU. And every patient is having these discussions and decisions made as they come through the front door, which I think is really important because patients are becoming more unwell. It's just really useful to have these conversations, to have this outlined early on.
Yeah. I saw something on Twitter the other day that, some physicians are having to have this conversation after it's already been escalated and they're having it with family, and it's over a FaceTime call, or a phone call, which is it's so difficult. That is really tough. So it's great that you guys are doing that. That's one of the things that I really hope does change just in healthcare going forward, that because we've had this opportunity to have these discussions, to realize that it's not quite as, it's still difficult, but it's something we need to do a lot more. Beth, in the palliative unit that you're working there, do you ever have the opportunity to still talk to patients and talk to patients' families about this type of things?
So obviously in the acute medical unit, it's very busy. They've got a lot of patients coming in. So they are having these discussions, which is brilliant. But it's often the case that the relatives aren't informed of that decision that early on. So then sort of the day after or that evening, they come up to the wards, and then we will sort of take it upon us to share that decision with the relatives, which is obviously incredibly important, especially if the patients don't have a phone or they're too unwell to speak to their relatives themselves. Just getting that information across to the relatives is important. And I think being on geriatrics, I've had quite a lot of experience with these discussions, which is brilliant. So I feel quite prepared. But the guidance that has been coming out from the trust is brilliant. They keep sending us sort of leaflets and things about how to have these discussions for all the juniors who perhaps haven't been in the situation that I've been in. So that's brilliant. Talking to the next of kin is obviously very difficult for a junior doctor as well, telling a husband or that their loved one isn't going to be for intensive care because they're too old, they're too frail, and the treatment is very unlikely to work. We normally have those decisions face to face because they're quite emotional, but having it over the phone is difficult. But I think the public have also been brilliant with these discussions because they know what's going on. They know that they can't come into hospitals. So they're being very understanding, and they're sort of taking it in their stride as well to have these decisions with us over the phone. And I think most of the relatives are just incredibly thankful that we are updating them.
Just on the back of that, Beth, these discussions with regards to end of life are very challenging, and particularly for junior doctors. Before the COVID pandemic hit, were you having as much discussion at the time, or has that increased now that staff levels are shortened and that sort of thing?
Yeah, it's definitely increasing. I was working on a geriatric ward, so there was a lot of these treatment escalation plans and there was a lot of these discussions with families. But now, obviously, a lot more people are dying and a lot more people are needing to have these discussions. There would often be the case where it would slip through the cracks and some people wouldn't have these forms at all. But now it's incredibly uncommon to see any of them not have them when they get to our ward. So definitely a higher number of these discussions.
Are you feeling supported as a junior from your more senior staff to have these discussions?
Yeah, throughout my first year, we've had a lot of senior support. And obviously the first time that I had this discussion, I was with a senior doctor and I learned a lot from them. I don't think it was until the fourth or the fifth time that I actually had the discussion myself. I just sort of sat and listened and took it in originally. But I feel like I've already been prepared from the past 6 months to have these discussions because I was doing them by myself before the COVID pandemic hit. So I feel like I've had enough experience to have them. But obviously it's a completely different situation and some of the conversations are challenging. And there is always senior support on the ward. So if I did get into any difficulty, I assume I could just grab one of them and say, oh, do you mind just speaking to this relative for me? So I do feel supported enough if I did need the extra help.
Yeah, that's great. I mean, honestly, you guys, I know that this is such a tough situation, and it is stressful when you have to start having those conversations, regardless of whether or not you're in this crisis. You're getting some experience that you are going to take with you for the rest of your career because you're good. This is something that you will do for the rest of your life whenever you're dealing with patients, and to have this, that you learn how to have a frank discussion, to be sensitive, but also to realize the absolute importance of it. I hate to say it's a silver lining because you never want to be able to talk to someone about death. You hope you can, everyone lives, but we know that's not the case. And so to have that's a really unique perspective. When it is at the end of life for these patients, we never want these patients to be able to be by themselves, or, not have someone holding their hand and not someone be at the bedside. Are you able to be in the rooms with patients as they're, passing, or is it, are there like staff that are kind of designated to do that? Because I really feel like that's such a huge part of the care that they can get. And normally, when they have family there, it's a little bit, more, easier to kind of deal with.
So when we recognise in the hospital that someone is actively dying, we have a specific guideline set up for these scenarios, and it's called the Purple Butterfly Pathway at Southmead. And it essentially guides us in changing our focus of care to comfort care and symptom control, which is really important. And that means that nursing staff are checking on patients more regularly and looking for specific signs and symptoms and giving medications to alleviate those. So that's one way of how we're spending more time with patients at the end of their journey. But it is tricky in this scenario because we're not allowed to go into the rooms as much because of the exposure risk. Mm-hmm. So it is really tricky. And I think that's been challenging for us as doctors and also for the nursing team and the healthcare assistants. It's been tough for everyone.
With regards to when you see patients and escalating their treatment, do you guys feel comfortable in recognising when someone needs to go to ITU, for example? And do you have the support from senior staff to make that decision? Because sometimes it's a really difficult decision. Should I be sending them on? Should I not?
Chloe?
Yeah, I was going to say, I think that would definitely be, whilst we might be the sort of the first ones around on the ward or the people who are there all the time and seeing these patients, those sort of decisions are definitely senior led and they're incredibly well supported. This wouldn't be something that a junior doctor like ourselves would be expected to make that decision. If we might be the ones who would recognise the early signs that a patient might be deteriorating. So maybe their oxygen requirements have gone up, their respiratory rate's gone up. And then at that point, we would then escalate to a senior. We wouldn't be expected to be starting these conversations with the intensive care unit. The whole sort of respiratory team has been mobilised around the hospital, and there's consultants floating around between all of the wards. And every day that I've worked in the last 6 days, I've seen a respiratory consultant first thing in the morning at 8 a.m. and they've written their phone number down somewhere on the ward and made it clear that they're around and they're available. So we are sort of around and recognising early signs. It's not us who's necessarily leading those decisions.
Consultant is like an attending, right? That's step up on a doctor.
They're the most senior person around.
You may not be making the decisions, but do you feel like you're kind of starting to get a little bit clearer picture of what it looks like when you are escalating up?
So I think we're present for these discussions and we're definitely feel part of the team and included, but and it's useful for us to learn about the sort of signs and the sort of people when we're making these decisions as are they for ITU, are they not for ITU, sort of how you judge that. It's useful to sort of be exposed to that sort of decision making. But because we're in these times and because we're so junior, we wouldn't be expected to be making those decisions by ourselves.
Are you ever surprised by some of the decisions that are made in these COVID patients? I mean, have you seen them just kind of take a dive? Does it look just very different than what you were kind of used to before you started seeing them? Jess, yeah.
Yeah, so the ward I'm working on, the respiratory ward, we have most of the patients who are for escalation. So they're the young, sick patients. And I think before COVID, I think it was very clear who would be for escalation, who would not. But we've definitely had some situations that have been quite difficult for the team because there's patients who have been getting worse. And I think we would think, if it was just a pneumonia previously, that they might go to ICU. But actually, given that we know what COVID does for people and how unwell they can get with it, there's been some difficult times where patients haven't been for escalation and have just been made, what we were talking about earlier, kind of end of life, and have not been taken to ICU. And I think that's been quite difficult to kind of see that there's potentially slightly younger patients who might have been taken for escalated if it wasn't for the way COVID's affecting people. But there's lots of very experienced doctors in the hospital who are making those decisions on a case-by-case basis. It's always appropriate, and we're all kind of really supportive of all the decisions that are made and continue to give care to people at all stages of the escalation. So it's been interesting to see these decisions kind of evolve, and with all the different teams involved, like Chloe was saying, the intensive care teams, the palliative teams, all kind of coming together to make these decisions.
Yeah. lots of ethical challenges here happening.
Yes, definitely.
which is something that really comes with experience, for sure. But it's good to have everyone's perspective on, especially from you guys coming in with fresh eyes on the situation. So that's good. Yeah, absolutely. One of the points that we were talking about before we officially kind of started our conversation was the isolation that people feel through all this. Dolcie, can you kind of talk about that a little bit, about how, I mean, you guys had to self-isolate for 14 days, while you were sick and being away from it. So can you talk to a little bit about that?
So yes, it is affecting us all quite a lot, I think. Some days have been really stressful at work. And when that happens, I often do things to help with that. So I see friends, see my partner normally as well, who lives in Bristol. But a lot of things have changed, as you're aware. My family are 300 miles away in Cumbria. And so is my partner, actually. So I haven't seen my partner for about 3 or 4 weeks now. And my family since January. And I'm not sure when I'm going to be able to get home to see them. So that's really tricky at the moment. And it's also just not having as much freedom as normal. So not being able to go to gyms or out and about as much, not being able to go to the shops, not being able to go shopping as much as possible. It's just a big change, and it just feels quite isolating to be stuck inside quite a lot. I feel like I'm just going between work and home, which is not the best. Mm-hmm.
You guys are kind of lucky because there are four of you in the house. So, and you're all doing the same thing. So you can, you have a lot of people that you can bounce ideas off and do things. Chloe, can you talk about some of the, kind of your feelings on this as well, and what you guys are doing as housemates to kind of help?
In some ways, I think we're actually amongst the more lucky ones, because at least we are allowed to leave the house every day and go to work. And I've never been more excited to actually go to work and see colleagues, and no offence, but to see people who aren't the other 3 who I live with, and whilst obviously maintaining a safe social distance from everybody at work, it's quite nice to just see different people. So I think we're quite lucky, and I really feel for the people who have to work from home and who aren't allowed to leave their house at all. So that's one slight silver lining. But it has brought us closer together as a house, I think. We've been doing lots of jigsaws, house games. There's been lots of craft afternoons. So I think there's whilst it's slowed life down a lot and we're not doing anywhere near as much as we used to, and, missing out on lots of normal everyday life kind of things. I think in some ways, we're having fun as a house. We're seeing more of each other than we would when we were on our weird shift patterns of more night shifts and long days and weekends, and at least we're in more. So I'm trying to look at it positively, because otherwise I think that you just get down in the dumps about it.
Yeah, I love your positive vibe, Chloe. I can feel it. It's good. No, I mean, I think the one thing I didn't want to go into this conversation being a downer with talking about anxiety and things like that, Henry, because this is like one of the most exciting times in that you will ever have in your career. Those first weeks and months and years starting out, it's really so exciting. I know you want to get your feet wet. And, to some people, especially I would imagine for a junior doctor, is kind of like, put me in there. I am ready. Put me in, coach. I am ready to go.
I mean, yeah, we were having a conversation the other day about how in 60 years' time we'll be telling our grandkids that we lived through a pandemic, and we were fighting a pandemic in our first year of being a doctor, which is absolutely crazy. Hopefully we will all come out of it, and yeah, it'll be an incredible experience to take with us through our careers, in terms of sort of having these difficult conversations, treating patients differently.
Yeah.
Beth, do you have any words of wisdom or any encouragement for us coming in?
It's going to be difficult, and it's going to be hard work to start with, and you'll be slightly terrified, which is completely normal. We felt like that at the beginning, but because of what's happened, I think everyone in the hospital is aware that you're coming to work. They're aware that you're going to be feeling scared, and I think everyone's sort of banded together and feels like we need to support you as much as possible. So I think there'll be loads and loads of support there from everyone in the hospital.
Especially for me, though, I'm expecting a bit of special care from you guys, considering I'm going to the same hospital. So extra tender love and care here, please.
We'll try.
That's hilarious. Jessica, for you, any final words of wisdom for Henry and the like?
I was definitely very anxious about starting, but the NHS is such an incredible place to work. There's so many people all working towards the same goal. Been inundated with support from the general public. It's been amazing in the UK. Like once a week, we've had people kind of clapping for us in the streets, and we feel really supported by the public. And so I think, Henry, you're coming into such a difficult time, but I think you'll never feel more appreciated as a doctor. And we also appreciate the public kind of staying at home and trying to stop the spread of this virus, because we're the ones seeing how it's affecting people. And yeah, the country's in a really interesting time, but the community definitely feels like it's never been stronger. And I think we'd all agree that it's really nice to see, people communicating more and being really supportive of each other. So I think if you just kind of hold on to that when things are tough, I think you'll realise, why we're doing what we're doing and how important it is to stay positive and support each other. So yeah, you'll be great, Harry. Don't worry.
That's awesome. That's awesome. The resilience that I see in you guys it's great. It's refreshing, especially because, a lot of us that have been doing this for a long time, it's really stressful. And I mean, it's stressful for everybody, but to have your young blood, I think is probably a breath of fresh air for a lot of us to see you coming. Henry, do you have any other questions?
No, I'm good. I just wanted to say thank you very much to all of you, really, for what you've been doing and what you're giving up, to be honest, to help others. It's really inspirational. You've also assured me with confidence for feeling, ready to start next week or the following week. And I'm looking forward to it.
Top Med Talk.
Thank you for listening to Top Med Talk. You can always find us on Twitter, LinkedIn, Facebook, and on topmedtalk.com. We want everyone to stay safe. If you have any questions or you want to talk to us on Top Med Talk, please reach out via contact@topmedtalk.com. That's contact@topmedtalk. Thanks for listening.
Top Med Talk is proud to thank its sponsors, specifically Edwards Life Sciences, for their generous support through this global crisis.